So hello everyone, and welcome to the Enhancing Clinical Practice and Outcomes stream of SNOMED Expo 2024. My name is Monica Harry, and I'm the Director of Content and Mapping at SNOMED International, and I'll be moderating today's session. All questions will be answered at the conclusion of the presentation. Online attendees, please use the Q&A button to type your questions to the presenter. On-site attendees, please use the microphone provided in the room. I have it here. I'll give it to you when you put your hand up. I'm now pleased to introduce Dr. James Campbell from the University of Nebraska Medical Center, who will present Implementing Social Determinants of Health Data to Promote Social Equity in Healthcare. Jim, please go ahead.
Thank you, Monica. I'd like to acknowledge my co-developers on this project, Jared Anzalone and Carol Geary at the University of Nebraska. They are a part of our research faculty, and we'd like to talk to you today a little bit about how we manage social determinants data when implementing into our electronic medical record. A part of this project was done in collaboration with two sociologists, Dr. Mary Campbell and Dr. Jonelle Parks of the Texas A&M and the University of Texas at San Antonio. And yes, Mary is my daughter, just to acknowledge our relationship. I also want to give a shout out to Jim Svoboda, who is a member of our development team, who developed the databases that are necessary for the community level data that I'll discuss a little bit later. If social determinants is not a concept that's on the tip of your tongue, I'd just like to clarify that basically they are not medical facts. They're not something about the practice of medicine, but instead they are those factors in our environment, our society, our culture, the geography of where we live and the political conditions where we're born, live, work, and die that basically affect our outcomes as human beings. Now, some of the more important social determinants of health that are well documented in the literature are things like socioeconomic status, what is your income, what is your occupation, your geopolitical location, food insecurity, whether or not you have access to food and the income to afford it and the like, housing insecurity, including what's available in your community and whether you can purchase a home that is useful, that is at your income level. And finally, cultural beliefs and roles, such as sexual identity, sexual preference, gender identity, skin color, and race. All of these things are basically roles that we play in interaction with our society that profoundly affect our ultimate outcomes as we travel life's paths. Now, social determinants of health are important to healthcare providers and to healthcare researchers, not so much because they're something that we can change, okay? They're facts of our lives, but it's increasingly evident that they are something that we need to understand relative to the patient that we're treating in order to provide the best outcomes for them. Goran and Whitehead did a bit of research a while back that basically demonstrated that the care we provide as clinicians contributes only a minority of to the outcomes that we experience, such as longevity, morbidity, and mortality. And in addition to that, to clinical care, health behaviors, social and economic factors, and the physical environment are major contributors to our health outcomes. Now, in the United States, I just want to mention that we have recognized the fact that social determinants need to be considered in the process of healthcare and need to be considered in healthcare research because of the fact that they are so important. And the Office of the National Coordinator for Health IT has begun to deploy social determinants assessments data into the clinical electronic health records and into our databases in order to support our clinicians and our clinical researchers. Now, right now, the structured data is limited from the standpoint of use of alcohol and physical activity, smoking status, drug use, race, ethnicity, sexual orientation, gender identity. But this data set is growing. In addition, I'm sorry, I got a point here. Social determinants data has begun to appear on the problem list and on assessments data. Concepts such as social determinants interventions and goals are at a formative stage because we don't know exactly as a clinical group how to manage them yet, but that's something that's under study. In addition, in U.S. electronic health records, ICD-10-CM codes, called the Z codes, have a lot of information about social determinants, but the reporting is spotty, and it's not something that you can reliably use as a fully informed data source. Clinical observation data, which are generally in our electronic health record as link codes or SNOMED CT observables, the assessment tools are evolving and becoming more numerous, but deploying them into clinical environments and getting that data gathered and recorded in a structured fashion is still at its infancy. One project that I should mention is the HL7 Gravity project, which is spending a lot of time organizing and identifying the tools and the data artifacts that are important in recording social determinants of relevance to the patient. And right now, those are published in the Value Set Authority Center from the National Library of Medicine. And I was happy to see in 2024 that the number of topics that are covered in those value sets are much more extensive than just a few years ago. So that's clearly activity that is ongoing. I want to talk to you today about my perception of a problem as a data scientist managing a big database extracted from our electronic health record. I retired from clinical care and I'm entirely in research now. And I can tell you that an electronic health record is a big data set. And it's designed basically primarily to serve the clinical community. So for that reason, the data is not, as I said, is not always oriented towards social determinants of health. And because there's so much data in the electronic health record, the indexing of that when we extract it into our data warehouse for research is something that's quite a challenge. If you look at the data content in electronic health records today, not surprisingly, virtually half of it or all of it is representing healthcare behaviors and clinical care process, because that's the primary objective of the electronic health record. And so that means that the social and economic factors and the physical environment were not designed into the electronic health record. They're beginning to appear, but all of this, I think, is at its infancy in U.S. healthcare. So even though the scope of the social determinants data set includes facts about the social and personal history of the patient, speaking in my former role as clinician, gathering these data in the clinical workplace is also difficult because we're talking about many times sensitive information that can't be discussed, for example, in the waiting room, that's for sure. So getting all of those data gathering items into our workflow is a challenge in itself. Psychosocial patient data, such as gender identity or sexual orientation, is an example of the challenge that I have as a data scientist in terms of how to capture that with sufficient metadata that in a big database with tens of thousands of variables, literally, how can I answer the questions about, do I have data for this researcher on gender identity because they want to study it? That's the problem I faced. And the problem is magnified by the fact that when you look at the observable entity for gender identity in the current international release of SNOMED CT, notice that it's a primitive. That means that in the concept model for observable entities, it is not fully defined, and it's basically stuck into the hierarchy by an editor with good intentions for making it available. But, you know, the advantage of a fully defined concept is that you can use the power of the SNOMED CT concept model to identify a random topic or theme in the database and pull it out. And I'll show you what I mean by that in a second. So in basic terms, the primitive status means that the analytical use of data on this item down the road when you're outside of the clinical context is a challenge. And I want to discuss how we might meet that challenge. And my assertion is that if we define our SNOMED CT data concepts fully with a SNOMED concept model as it's available today, in a well-developed ontologically guided protocol, such as the Observables project group was providing. This serves as a rich source of metadata, basically a terrific index into this big database that allows you to go in and pull out themes or topics such as social determinants, if in fact we had them fully defined. And we don't today, but I want to discuss that. So at Nebraska, we expanded our extension namespace with clinical observables for the patient level social determinants data, such as gender identity and sexual preference. And in our analysis, we talked with the Observables project group and decided that these represented by and large process observables. And you don't need to know what the technical details are on that. But basically, it sets up an ideal concept model for definition of an element within that group. And part of that definition rests upon what processes are involved in are the processes that are being studied. And what I'm proposing to you today, and what we did in our extension namespace at Nebraska, is we expanded the process hierarchy in qualifiers, which is the defining element, which is one of the defining elements for process observables, to include a lot of things about human activity, human psychosocial processes, such as how you're assigned ethnicity, how you're assigned a gender role, how you're assigned a racial role, and other things such as human social and cultural activities, including things about education, financial management, human community building, etc. We don't need to go into all of those in detail, but my point is that we're modeling society and what's going on there in terms of all the interactions of, gee, that fellow's skin color is dark, you know, he must be black, okay? That's the type of interaction that is going on every day and basically altering in many ways our path through this life. Let's think a little bit, for example, about gender identity data, okay, and how that might play out. Here you see the way that we modeled gender identity, okay? And this is now a fully defined concept, all right? And the concept model here, each of these attributes defines a particular feature of the observable. And I've summarized on the right there, basically what the metadata says from this model is that this piece of data is about the patient. It's about the gender role that they accept, okay? It was made at a point of time, okay? And that it was obtained from the patient by interview. And the results of this observation are a SNOMED code, which is basically for the gender identity that they accept. Okay, well, why do we care about that? If you take a look at an ECL, and what I have done here, for those of you who are not familiar with this, expression constraint language is a manipulation tool that allows us to use the concept model to reach into the database and grab a bunch of things that meet our purpose, okay? And this particular ECL is looking for observations that are made about the human gender assignment process, okay? So what are the results when we look at it? Okay, sure enough, down here we've got a LOINC concept for what was the patient's sex at birth. And then in addition to that, what is their current reported gender identity? We have also set up our computable phenotypes. Those are queries into our electronic health record. We have a computable phenotype that looks for any history of gender disorder in the patient, okay? That's a query of the record for that patient, comes back with a piece of data. Yes, they have a gender identity disorder or not. And that is a data item that we have maintained. And what is this stuff here? The number of residents who are female in the community where the patient resides. Well, the gender mix in the community certainly is relevant, may be relevant to information about this patient's gender. Maybe not, I don't know. And I'm going to talk a little bit about community facts, which is what these are, okay, here in a second. But in the meantime, think about the issue of answering a question from the clinician. Do I have any information about gender problems on this patient? Or do I have any, from the researcher, do I have any information about gender problems in my patient population? Okay. And I would observe that in SNOMED, as it's used in the electronic health record, basically these data will be found in clinical findings in the problem list. In LOINC terms, you know, we have a collaboration with LOINC, and they have a close relationship to the graph project, and so LOINC terms are relevant, and also SNOMED observable entities. And it's my assertion that the ability to analyze and answer questions such as the one from the clinician for decision support and research is enhanced in large data sets by fully defining our social determinants data in the way that I have begun to discuss with you, and inclusion of the appropriate observable entity in the clinical finding. And technically what that means is the clinical findings in the problem list are connected to the observation result that basically prompted the problem list. So this is a larger set of data, but all about a particular topic, okay? What does that mean? Well, for example, a particular example that I've encountered, with one of our research community, do I have any information about patients with and their smoking status? All right. Now, this is another ECL which you don't have to understand except from the standpoint that it basically looks in two parts of the medical record. Clinical observation results here, and it basically is looking for data about the process of human tobacco use, okay? And secondly, it looks at the problem list and the medical history and looks for clinical findings, which is interpreting an observable, which happens to be about human tobacco use, all right? So basically, the problems that are relevant to the patient, to the patient, and the results of the observations. And when we go ahead and execute that, and this is the Snowstorm terminology server, okay? It is basically a tooling platform that allows us to use the power of SNOMED to identify where in this big database of all of these concepts and everything are the concepts that I'm interested in right now. In this particular case, smoking behavior. And you can see that, sure enough, right here, we've got what's the patient's smoking status. And then we've got a bunch of problem reports in the problem list or the past medical history, which are clinical findings. And they're all linked together basically by the definitions that are present in the concept model. So remember at the very beginning, we talked about non-medical factors that basically are about us and the places we live, work, and die. And so what about those places? What about the information on those, the community? And a second part of what we did was basically in consultation with our sociologists, we identified numerous resources that are available across the U.S. On data sets that are of relevance to social determinants of health. And in order to computably define assessment results about these communities, we had to extend the SNOMED concept model because there was really no reference to how to identify a fact about where you live. All right, so that all of that was some additions we made to in this, again, going back to the concept model. We added information about community processes, things such as housing construction and acquiring shelter, things that involve clothing, food, etc. Basically, other social determinants factors that we wanted to evaluate. So let's just talk quickly about housing insecurity, okay? Human shelter acquisition with a subtype of facility and housing construction. And when we go ahead and do that search for those processes, here is the fraction of households in the community where there are not complete plumbing facilities, okay? And this assessment happens to be about the community where the patient lives, the quality and quantity of the housing construction at a point in time obtained by survey from the Department of Census. The results are a number, basically, and it's the fraction of households with a deficiency. Or another fact from the Social Vulnerability Index, all right, which is about a composite score, actually, of transportation and housing construction. And it's from a CDC database that's maintained and gives us a numeric score that ranks that community nationally. And using the same techniques that I used before, we can therefore query our problem list, our past medical history, our observation facts, and look for all of the facts that are related to housing insecurity. And you see that here we have some findings about custodial care facilities, difficulty accessing a home from the problem list, data from the Social Vulnerability Index. So when the researchers asked me, do I have any information about housing insecurity, I can give them an answer fairly quickly. Now, this is all pretty complex, and I apologize for winding you through or taking you through such a winding path. But social determinants of facts are necessary, of health are necessary for good clinical decision making and good clinical research. The electronic health record database is not organized to let me get at that data quickly and easily by subject matter. Current US efforts to provide those paths, okay, are still basically at a startup phase. And so deploying expansions to the SNOMED concept model, defining our data fully, will make it available to the researcher and the clinician for all of those things that they really need that data for. And I thank you for your attention.
Thank you, Jim. Now we will take questions. Does anyone in the room have questions? First of all, I'll check the online. But if you do have a question in the room, I have a microphone to give to you.
Kim Fung from U.S. National Library of Medicine. So Jim, your proposal is basically a way to improve the modeling of SDOH concepts, right, in the SNOMED. But as you also mentioned, that the sparsity of the data now in the EHR is probably not related to the lack of codes because you have ICD-10 codes, but there is the lack of the motivation or incentive to put that code in the EHR. So do you have any ideas of how that problem can be addressed?
Well, I think it's fair to say, Kinwa, that the Office of the National Coordinator is doing everything they can to incentivize that, okay? But it's a process. In the meantime, I think we need to be able to gather that data efficiently and quickly, when it is needed. And I think we need to have a process that is scalable as we go forward and get more data. It's also why we've, looked into community resources as supplements in many areas that are available today, but are not routinely integrated into electronic health record data sets. So SNOMED has a lot to do, okay? And quality improvement, such as working on the concept model and social determinants, is one of lots and lots of tasks, as Monica can accept.
And with that, we will conclude the session. Online delegates, you can stay here for the next presentation, which is coming any minute, or another session in the event lobby as you prefer. Thanks, everybody. Thanks, Jim.